Thank you all. We're on, good. All right, hopefully we'll get some people back in here after what may be a bathroom break. As you heard in the introduction, I'm a physical therapist at Johns Hopkins. I work with both children and adults, and I thought I'd share how I got involved in CF since our other speakers have done so. I just happened into it. PT is a regular part of CF care at Johns Hopkins. We see our patients 3 times a day when they're admitted to the hospital. So when I started working there, I got to know a number of the patients quite quickly. But then I learned we had hundreds of other patients who weren't getting admitted to the hospital, and I pushed to get more involved and actually see patients when they were healthy, when they're coming into the outpatient clinic. So I have no disclosures, not currently involved in any grant-funded research. And what we're going to do today is talk about general exercise guidelines, not just for people with CF, but for everyone, and then look at the differences for people who have CF. We're going to talk about the dynamic core system and discuss the neuromuscular and musculoskeletal complications that are prevalent in the CF population. Dr. Clancy had us looking through the microscope, and we're going to really zoom out and look at the bigger picture, look at the whole body today. And then we're going to talk about the physical therapist assessment and treatment options. This is one of my favorite graphs for looking at how far we've come with CF care. See if the pointer, maybe, yep. There. So up and down on the left side, you see how many thousands of people are living with CF, and across the bottom is the year. So back in 1986, there were about 10,000 people under the age of 18. So the green represents people under the age of 18. The blue is people over the age of 18. So a lot more kids than adults back in 1986. And you can see as time goes on, that adult population has really grown, and it's continuing to go up and up. So it's super exciting that more than half of the population with CF is now living into adulthood. And what this means is that our team has grown also. We have our core team members, with patient and family being first, the physician, the rest of the core team. But the team has grown, and most teams will now include a pharmacist, a psychologist, a research coordinator. You have your ENT doctors, your endocrinologist, and physical therapists. And physical therapy and respiratory therapy are an area where we have overlap in the care that we provide. Depending on the center you're at, you may have an RT who is administering the airway clearance, or you may have a PT doing it. But beyond airway clearance, we can really go our separate ways. So it's actually pretty cool that as of last year, the CF Foundation no longer has a slash between PT and RT as one of the requirements for your annual screenings when you go to clinic, but now there are 2 separate boxes, one for respiratory therapy and one for physical therapy. Back in the day, this is how PT was involved, primarily to provide chest PT. But as we've gone on and moved beyond the lungs, it's not just chest PT. There are other airway clearance techniques. And PTs are also addressing things such as endurance, strength, flexibility, bone density, continence, posture, pregnancy, pain, and ultimately improving quality of life for our patients. So no longer just pediatrics, but also geriatrics. And something that we kind of joke about at Hopkins is that we're going to need a geriatric clinic eventually. And as the years go on, it's becoming less and less of a joke and more of a reality, because it's pretty cool. As our patients transition from pediatrics to adults, they have different needs than they did when they were kids. And then as they become older and older adults, those needs are changing also. All right, so let's move on and talk about exercise. We're going to start with just the general benefits of exercise. These are benefits that all of us, whether or not you have CF, will reap from exercising. We live longer and healthier lives. We can improve our immune system, reduce fatigue, improve sleep, boost your mood. Don't worry about weight loss. For if you have CF, we're going to talk about that. Lower your cholesterol. Improve blood flow. Exercise can be a natural painkiller. It can slow cognitive decline, reduce all kinds of cardiovascular complications. It allows for quality time with family and friends. And ultimately, why should we exercise? Because it's fun. It shouldn't be a chore. It should be something you enjoy doing. And there are so many options out there for exercise. So hopefully we can all find something we enjoy doing. How much should we exercise? The CDC recommends that kids and teens should be active for at least 60 minutes a day. Adults should be getting at least 150 minutes per week of moderate to vigorous activity. So that's activity that gets you short of breath, that gets your heart rate up. Preferably that number is closer to 300 minutes per week. And that may sound like a lot, but really 150 is 30 minutes over the course of 5 days. Or 21 minutes over the course of 7 days. And it doesn't have to happen all in one chunk. It can be a 10-minute walk into work, a 10-minute walk during lunch, and a 10-minute walk again after work. Most of that should be aerobic exercise, but you also should be doing strength training and stretching. So how about CF? What are some exercise benefits specific to CF? One of the more obvious ones, it's going to improve your exercise capacity if you exercise. You're going to get more fit. It's going to slow decline in lung function. You're going to improve mucus clearance, improve your quality of life, and improve nutritional outcomes. Research has shown that those people who exercise more have a higher BMI. Now, most people would be confused if I'm talking about exercise and they see a picture of a cheesesteak on the screen, but I have to share a story about one of my patients. I was going to see her. It was her last pediatric visit before transitioning over to adult care. And I went in the room and she just looked great. She had a smile on her face. You could tell her weight was up. Her color was good. And I was just like, wow. What have you been doing different? And she was so excited to tell me, I'm exercising. I was like, really? What are you doing? Tell me about it. And she said, I go to the gym about 3 or 4 times a week, and my reward to myself after I exercise is I stop at my favorite place and I buy a cheesesteak. And then I go home and I do my airway clearance, and then I watch my favorite show while eating that cheesesteak. And it was just the perfect picture. And, I wish everyone would do that. Like, go out and buy your cheesesteaks after you go to the gym and pack those calories back on. So, exercise in CF, it wasn't always recommended. I actually have a patient who just recently was having a hard time grasping the concept of that she needed to exercise. And she said to me, Karen, back when I was little, Dr. Rosenstein told me not to exercise. She was born in the 50s, and I still work with Dr. Rosenstein, so the next day when I saw him in pediatric clinic, I gave him a hard time. It wasn't until the 1970s that exercise was recommended for people with CF, and at that time it was really just general exercise. Now, there have been a lot of studies that have taken place looking at different types of exercise for people with CF, but it wasn't until almost 2 years ago when the CF Exercise Special Interest Group published 3 different articles that really gave us guidelines for how people with CF should be exercising, what kind of exercise testing should be done, and what we should be concerned about as far as contraindications or considerations for people as they grow older or as the disease becomes more severe. And you know what they came up with? Exactly the same recommendations for those of us that don't have CF. There are those the special considerations, which we'll get into, but people with CF, if you're a kid, you should be moving around for at least 60 minutes a day. If you're an adult, at least 150 minutes per week. You should be doing aerobic exercise. You should be stretching. You should be strengthening your muscles. So how do we exercise? We start when we're infants, doing normal things like tummy time, pulling to sit, supported sitting, bouncing, doing so big types of things that are going to open that chest up. These are all things that we do with babies, whether or not they have CF. As they get older, it's crawling and climbing, pulling to stand. Toddlers, high-intensity interval training. That's kind of a hot topic in exercise now. Toddlers are natural HIIT athletes. They go hard and then they rest, and they go hard again and they rest, and they're doing HIIT training, that high intensity interval training, all day long. This is also the time when it's important to establish a positive culture of exercise, so doing things together as a family. As the kids get older, it's about establishing the bone bank. Osteopenia and osteoporosis, or thinning of the bones, is something that is common in people who have CF. So really doing exercises that are going to strengthen the bones and build that bone bank. Kids are going to get involved in teams. Giving them choice is important. Of course, things like swimming and soccer are going to be more beneficial to the lungs than something like golf or baseball, where you're not running and moving as much. But I would never discourage a child from doing something that they wanted to do, but trying to promote things that are going to be better for them. As we move into adulthood, we may need to modify things based on disease severity, based on family life. It can be hard to fit it all in if you're, raising a family and chauffeuring your kids around to different sports. It may become, you doing laps around the field or the track while your kid's at practice, or doing some dips or push-ups on the bleachers so that you can fit it in when you can. Just another look at different types of activities to allow to get that exercise in. I'm not going to read through all of this, but it's normal stuff that kids, teens, adults without CF or with CF should be doing. You have the aerobic activities, strengthening activities. The one thing under toddler that you may not be familiar with is the glue game, and I think any pediatric therapist has a fun time with the glue game, because what you do is you dip your imaginary brush in your imaginary bucket of super glue, and then you paint it on the patient, and you stick them to the wall or to the bed, and you try and move their legs or move their arms after they've been stuck down, and they have no idea they're doing it, but they're working on their core strength, they're working on their leg strength, their arm strength. So the glue game is a really fun one. And then stretching activities. Yoga at any age is great. For toddlers, making their bodies into different letters or animals, stretching over the ball. As you get older, it can be a little bit more structured exercise, dancing, using foam rolls or different objects to stretch out. So if all of these things are normal activities, normal recommendations for people who don't have CF or people who have CF, why do we need PT? We need PT because people with CF may be getting short of breath with normal activity, tight, shallow breathing. They may have hemoptysis. They may have stress or anxiety. They may have back pain. They may just have really low lung function, and they're scared to exercise. You don't know how much is enough or how much is too much. Moving on, we're shifting gears, and we're going to talk about the gears of CF. I used to think of giving patients recommendations, things to do, as another piece of the puzzle. For CF, there are a lot of different pieces of the puzzle that have to come together for everything to be good and for you to be healthy. But that seemed pretty static. Our bodies are always in motion, they should be in motion, and the disease course of CF is constantly changing. So let's think about it like gears, okay? You have your nutrition, your enzymes, your tube feeds, you have those gears. You have your breathing exercises, your vest, your nebulized medicines. You have your mental health. You have your everything going on. And if one of those gears gets rusty and starts turning a little bit slower, it's going to affect the other gears. If you think about how those gears turn together, one slows down, the rest of the system is going to slow down as well. If your lung health goes downhill, you're probably going to have a drop in your nutrition, your BMI as well. Your mental health is going to be affected, right? So let's zoom in and look at our core gears, our core machine. Our bodies are machines, and at the center of this machine is our core. Now, when you hear core, you may think about your obliques and your six-pack muscle, but I want you to think about these four muscles specifically. Along the back is the multifidus. It's a deep spinal extensor muscle. It helps to hold the spine upright. We have our transverse abdominis, which wraps around from back to front. Think of it as an internal corset that provides support. We have diaphragm. I lost the little red thing. Diaphragm on top, pelvic floor muscles on the bottom, okay? This is our engine. This is the foundation for our body. What Talaz and colleagues showed is that with every breath, both the diaphragm and the pelvic floor muscles are moving. They're working. Your core muscles aren't just working when you go to move or run or jump or reach. They're working with every single breath. When you breathe in, the diaphragm moves downward. That puts more pressure into the abdominal cavity, and then the pelvic floor muscles descend also to absorb that change in pressure. When you blow out, both the pelvic floor muscles and the diaphragm rise back up. So even though our heart, our brain, our lungs, all those internal organs are super important, we're not going to be able to move or function much without these core muscles here. Every breath you take, even before you move, these muscles are active. And it's not just with breathing, it's also our support, our posture. Every muscle of the trunk, not just those core muscles, are both respiratory and postural muscles. So when you grow up with a pulmonary disease, something that affects your breathing, it's hard to keep the balance between breathing muscles and posture muscles. Your brain, your central nervous system is always going to direct you to breathe. So you start doing a lot more for breathing and you start seeing compensations in the postural and movement aspect of these muscles. You with me? Yeah? Okay. So let's look at this in a different way. Think of your trunk like a can of Coke, okay? This is my can. That thin aluminum can alone is pretty weak and flimsy. That's our skeleton. Just the bones would be floppy without the contractions of the muscles of the trunk and without the internal pressures regulating, okay? At the top of the can is the vocal folds that keep the pressure closed here. At the bottom of the can are your pelvic floor muscles. You have your thoracic cage, your thoracic cavity and your abdominal cavity separated in the middle by the diaphragm. The diaphragm is the pressure regulator, okay? It helps those pressures shift up and down as you breathe and as you move. This helps to regulate all of the functions of our internal organs. It helps to hold up our posture, because if we lose that pressure inside, if you open the can, think about how easy it's going to be to crush the can, right? You can't crush a can when it's full and when it's sealed. You can't do much to your structure when you have muscular contractions and internal pressures supporting it. But in someone who has, say, a spinal cord injury, where they've lost control of their muscles, that skeleton kind of collapses on itself. The opposite is true in CF. You're coughing and generating great pressures inside your thoracic cavity, and those pressures are trying to push outward, okay? It's like when you freeze a can of Coke, and that pressure is trying to get out. Pressure is going to find the weakest point to release. So this is when we see the barrel chest, okay, that wider chest. We see the kyphosis, that forward curvature of the spine. We see it in stress urinary incontinence. We start to see lots of changes that occur because this pressure is trying to get out. It's easier to prevent these changes from happening than it is to change them once they've happened. So when should we start? We have to start young, okay? We know that in the CF population, we're seeing musculoskeletal changes as early as the prepubescent years, somewhere in the 8 to 12-year-old range usually. These changes show up as kyphosis, the forward curvature of the spine, as scoliosis, that S-shaped curve to the spine, decreased lumbar lordosis. So your lumbar spine should curve in a little bit, but what we end up seeing in CF is this kind of thing, where the bum is tucked under and that lumbar spine is flattened. We see muscle weakness, we see arthritis. All of these things lead to a number of different things: pain, decreased endurance, decreased exercise capacity, decreased quality of life, increased in pulmonary exacerbations, and stress urinary incontinence. And yes, I said it, stress urinary incontinence. It happens, okay? Leakage of urine, peeing your pants, whatever you want to call it, it happens in CF. The studies I don't think are super accurate because I think it's something that people are embarrassed about, so I do believe it's underreported. But the studies that are out there show that at least 30% of female adolescents with CF have reported urinary incontinence, and that more than 70% of adults have urinary incontinence. There was one study that documented 100% of female adults have urinary incontinence. It happens in men and boys also, but not nearly as frequently as it does for women. People don't mention it to their care providers because they think it's not related to CF, or they're embarrassed, or maybe they're nervous about treatment options. Maybe they've heard about internal exams and they don't want to go there. But it's important to talk about it. It's important as care providers that we ask the question, and it's important for patients that they tell their care team everything that's going on with their body, because chances are it's probably related to CF, whether it's incontinence or something else that you're experiencing. Once a patient was so excited when I asked her about incontinence, and I never had anyone be so excited about it and admitting it, but she said, "Karen, really, it's related to CF? Thank you, I thought I was just getting old." And she is, I mean, she was in her 40s when we had this discussion, so in CF world, that's old, but you know, like you saw on that graph, that's not really old anymore because people are just living longer and longer. So yeah, it happens, but it's not normal. It's common, but not normal, okay? It's something in CF that we can fix, and that's why I like talking about it with patients, because you know, Dr. Clancy talked about all these changes that are coming, and hopefully really soon we will be able to fix CF forever, but in the meantime, PTs can help stop you from peeing your pants, all right? So don't be embarrassed about it. What else can PTs do? So what our assessment looks like, it starts when they're young. We actually start seeing patients at time of diagnosis. So we usually don't see them their very first visit to clinic, but their second or third, we're introducing ourselves and talking about all that PT can do. We look at breathing mechanics. We look at posture, range of motion, strength. Exercise assessments should be done. We talk about pain, we talk about incontinence, and as I mentioned earlier, depending on your center, you may or may not have a PT doing the airway clearance aspect. At Hopkins, we are the primary providers of airway clearance, so it's just one more thing to add to the list of everything we try and get to during a quick screening visit. So, breathing mechanics. How do we look at breathing mechanics? I can just look at someone, an eyeball, and say, oh yeah, you're using your diaphragm, I see that rise and fall of your abdomen, or oh my gosh, you're using your upper chest and your shoulders trying to really pull in as much air as you can. I can do a hands-on assessment and just again kind of eyeball it and look, is your chest expanding? You know, are my hands moving apart from each other? Measurements is something that I really like to do, taking a tape measure around the chest and looking at how much expansion people get with normal breathing and also with deep breathing, doing measurements for the upper, mid, and lower chest. So if I see something not right, what do we do about breathing mechanics? If you think back to the piston, and for that piston, the rise and fall of the diaphragm and the pelvic floor to work properly, they have to be lined up on top of each other. You need your rib cage to sit on top of your pelvis. And if you're in this kind of position, the pelvis is shifted forward, the rib cage is slanted, that piston isn't going to work. So what I did with this patient here is I laid her down so she was relaxed, supported on a wedge because she didn't do well being completely flat. But this eliminates gravity. It eliminates the work that the muscles have to do for their role to support posture. So we could truly break it down and focus just on the breathing mechanics. I used a wedge there. I have towel rolls just to support her and get her lined up, and then used specific verbal cues or hands-on cues to promote more diaphragmatic breathing, less upper chest, and also to make sure that she was letting her pelvic floor muscles relax and allow that piston action to happen. Moving on, our posture assessment, and this woman you can see does not have good posture. She has a pretty significant scoliosis in addition to having CF. I'm going to look at posture both in sitting and standing from the front, side, and the back so I can really get an idea of what's going on. Looking at position of head and shoulders, spine and pelvis, and down through the lower extremities, the legs. I really like to take pictures because I think they can give a good before and after, both for me and for the patient, so they can see the changes. But there are other tools, goniometers, flexible rulers, et cetera, that you can use to track or to measure posture. I'm also concerned about posture during airway clearance. On the left is, I would say, a pretty common posture that a lot of patients may sit in while they're doing their breathing treatments, while they're using their vest. But again, think about that piston. Can that piston work correctly when you're curved? And when you're doing your airway clearance, you really want to open your chest as much as possible to allow the air and the medicine to move through your lungs into, the deepest, smallest airways. On the right is one of my patients who is a horseback rider, obviously, and has beautiful posture. And what's interesting is when I asked her the question about stress incontinence, she doesn't leak ever when she's on her horse, even when she coughs. But she does leak when she's at home, inside the house. Why? The piston, right? The muscles can't work. They can't do their job when you're sitting in that bad posture. So if you're getting, spending all your time in this kind of a posture, the muscles aren't going to be able to do their thing, right? So let's try it out. I know some of you are slouching already, maybe sitting up straighter, so we've been talking about posture. Make sure everyone can see me here. So, slouch. Go ahead. Slide your bum forward in the chair. Let your shoulders round forward. Drop your chin to your chest. Don't move from that position. Take a breath in. Try and take a deep breath in. How'd that go for you? Now, sit up, come to the front of your chair, feet flat on the floor. Think about sticking your butt bones out behind you, lifting your chest proud. Try and take a deep breath in. Did more air go in? Yeah, there's a difference, right? So posture, posture, posture. Range of motion and strength, another part of the PT assessment. I don't look at every single joint of the body, but I do a quick screen looking at spine and pelvis, shoulders and hips. So I have patients bend forward, I have them bend backwards, I may have them lie down flat on their belly and lift up so I can look at extension through the spine. So when we spend a lot of time in this posture, our thoracic spine, the part from the base of your neck down to the bottom of your ribs, can get stuck in that position. In order to have good shoulder mobility, we need to have good spine mobility. So you guys want to stand up? You need to move around a little bit. Tuck your tailbone underneath you so you flatten the low back. Round your shoulders forward. Don't let your spine move, okay? I don't want you to straighten up. Raise your arms up. Now, lower them down. Lift up into good posture. Raise your arms up. Ah, feels good, right? So you get more shoulder mobility if you have good spine mobility. So think about a swimmer, a throwing athlete. Are they going to be able to perform at their best, whether it's, a 12-year-old playing in the local Little League or a college athlete or amateur pro? No, you got to have good mobility to allow your muscles to function. Or not even an athlete. Think about trying to reach up into a cabinet. Are you going to be able to reach that top shelf without having good mobility in your spine? And something that we'll see happen when I look at patients, tell them to reach as high as they can, they know this is as far as they can go, and without even realizing what they're doing, they compensate from the low back to get the arms up higher. And what that's going to do, that's going to overwork the lumbar spine and lead to low back pain. So it's a very cyclical effect of everything that happens. We also do a side bending. I really like to get a side bending measure where I have patients raise their arms up overhead and then bend to the side. And using a tape measure, I look at how much expansion there is through the rib muscles and then down through the muscles of the waist. We look at strength, shoulder and hip strength, abdominal strength, pelvic floor strength. By pelvic floor strength, I'm asking the questions. Do you leak? If they leak, I know that their muscles aren't working the right way. And there are, lots of different ways to measure shoulder, hip, abdominal strength. Exercise testing. There are different functional tests that can be done. A sit to stand test, where you time how long it takes someone to sit and stand 5 times. There's also a 30-second. How many can you do in 30 seconds? And more recently in the literature, specific for CF, they're looking at a 60-second sit to stand, because that's going to incorporate a little bit more of the cardiovascular aspect. How are your heart and lungs responding, as well as how much power, how much strength do you have in your legs. The plank, vertical jump, there are lots of different ways to functionally look at strength. There are also different field tests. The 6-minute walk test is probably one of the most popular ones, or most well-known. This is required as part of lung transplant workup. And the way this works is I set up a 100-meter course, cones at each end, and have the patient walk as many laps as they can in 6 minutes. Modified shuttle walk test. This one is going to give a little bit better results for people who have mild to moderate disease, because it's going to push them a little bit more. The modified shuttle walk test is similar to the beep or the pacer test, which a lot of kids do in school, where you have pre-recorded audio and you have to get from point A to point B. The first one is 20 seconds long. So you have 20 seconds to get from point A to point B, and then you wait for the next beep. And it's 20 seconds. And every minute, those beeps get closer and closer together. So you start out walking nice and slow, and then every minute you're gonna have to walk a little bit faster to make sure you hit the cone before the next beep. And it gets to the point where you have to jog and then run really fast. The 3-minute step test, which you see my good friend Holly doing with one of our patients here, is also pre-recorded audio, and it's set to a metronome. And you just step up, up, down, down, up, up, down, down, right on the beat, just up and down the first step. You do it for 3 minutes, and we're monitoring your heart rate and your oxygen and some other things while you go. So those are easy, quick field tests that can be done in most clinic settings. And then there's more formal exercise test. Cycle ergometry is the gold standard for people who have cystic fibrosis, and that's what you see here, where you're hooked up to extra bells and whistles. They're monitoring what's going on with your oxygen and your blood, and it's really going to give a lot of values that can help guide a very specific exercise program and find out where your limitations are. There's also a treadmill test, which people may be familiar with as well. Moving on, we're back to it again, talking about incontinence. So this is a side view of the female body, and this may help to kind of visualize why this is happening in CF. So this is a side view. Again, you have the butt and the spine. Right in front of that, the intestines going down to the rectum and the anus, the uterus, the bladder. So moving from back to front. The intestines are up above. So that sling across the bottom there are your pelvic floor muscles, okay? They attach back at the tailbone and loop around to the pubic bone in front, and all of your openings are controlled by those group of muscles. Think about when you cough and the pressure that's generated with a cough. It's not just in the thoracic cage, it pushes down into the abdomen and then onto those internal structures and eventually onto the muscles of the pelvic floor. So with repeated coughing, it may not happen when there are 2 coughs. Those muscles may be strong enough. Their sprinter aspect of the muscles works for those quick contractions. But when you're sick and have this repeated cough, 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 are these muscles the marathoner as well? Can they withstand? And are they set up in the right position? Again, this flattened lumbar spine and the pelvis tucked underneath shortens the distance of those muscles, and it puts them in a tighter position, and they're not going to be able to work as well, right? We need to realign the posture to make sure that we can strengthen the muscles appropriately. Think about your biceps as an example. This is your biceps in a lengthened position. This is your biceps in a shortened position. If your biceps is stuck in a shortened position, are you going to strengthen it if you can only do this because it's so tight? No. You need to lengthen it out first and then work through the full range. This is what's happening a lot with stress urinary incontinence in people who have CF. It's not just that the muscles are weak, but it's that they're in a shortened position and they're tight as well. Think about constipation, okay? If that backside is full of stool and it's pushing on those structures in the front and pushing down on the pelvic floor muscles, that's going to increase the risk. So one of my things with doctors, nurses, care teams not talking about incontinence is you talk about poop all the time, right? Isn't it a little bit easier to talk about pee? It should be, right? You never announce like, oh, excuse me, I gotta go poop, right? You may say, I have to pee, I'll be right back, but who says I'm gonna go poop if you're not two? So bladder and bowel are very much connected. If we're asking about one, we need to be asking about the other. I've talked about posture from the standpoint of the pelvic floor muscles and coughing, but it's also important when you're pooping, right? These pictures are from the Squatty Potty website. Who's familiar with Squatty Potty? Oh my gosh, really? You guys are missing out, okay? What this image shows, the sitting image on the left, shows that the rectum is being pulled forward, which means your poop has to travel at an angle to get out. That's when you're sitting at 90 degrees, okay? Your knee at the same level as your hips, your trunk upright. When you bring your knees up higher than your hips and maybe lean your upper body forward slightly, that puborectalis muscle is in a more relaxed position. It's not gonna yank the rectum forward and your poop can shoot straight out. So better emptying, faster emptying. So my favorite store now has one of my favorite products. Costco sells the Squatty Potty. You can get 2 of them for $30, all right? If you don't want to spend $30, a simple folding footstool will work as well, and you can usually pick those up for about $5, okay? So if you have a lot of bathrooms to stock and you don't want to spend a lot of money, go with the folding footstool option. And I took the picture out of my daughter with her feet up on a footstool while she was pooping, and I've had it in long enough, but in other talks, but she'll probably thank me for taking it out. All right, so what do we do for urinary incontinence? Beyond posture, what if patients aren't telling me that they have it? There are red flags that if I see certain things, I'm guessing you probably leak. You may not leak all the time, but you probably leak sometimes. Are they going to the toilet consistently before doing airway clearance or before PFTs? Do they sit with their legs crossed, trying to use every muscle they can to hold things in? Do they walk with scissored gait? Normally when we walk, our feet are a little bit apart, but if your feet cross each other, you're trying to hold everything in there. Poor posture, again, we've talked enough about that. Are they refusing to do airway clearance? I had a heart-to-heart with a patient a few years ago, and I was trying to break down and figure out, why aren't you doing airway clearance twice a day? You know you're supposed to, you know it's important. And finally she said, Karen, you know how you asked me about if I pee my pants ever? I said, yeah. She's like, I lied, I do. And when I do my vest, my whole bladder empties. And it broke my heart, because she hadn't talked to anyone about it, and she was sacrificing her lung health because it was just so much effort to have to change her clothes, to have to shower every time she did airway clearance. So we got her some help, and she does her airway clearance more often now, but it happens. Are they giving a weak effort on cough or during their pulmonary function test? These are all red flag things that, if I see any of them, there's a good chance that there's something more going on that patients aren't talking to me about. So what do we do? Posture and alignment, we've talked a lot about that. Address breathing mechanics, we've talked about that also. Retrain the brain and the muscles. So that picture where I had my patient on a wedge, lying down, training the muscles, that's great for teaching the muscles how to work in that position, but I need to sit her up I need to stand her up. I need to get her moving and make sure that those muscles can carry over and function the way they should when she's in the different positions. And some of that is retraining your brain and learning how to hold yourself differently, learning how to breathe differently. It's not something you can just say, okay, this is how you're gonna breathe, and boom, it happens. It's gonna take time. Huffing and coughing. This is so important for so many aspects. But if you're taking the time to do your airway clearance, hopefully you're doing your huffing as well. And I can't tell you how many times patients tell me, but I already cough, or I don't want to cough, that's why I don't huff. A huff is a more gentle way to move more mucus up, so you get more out with less coughing. There are so many not so good things that happen with excessive coughing. You know, it puts your posture in a not so good position. It's wear and tear on the airways. It's exhausting for patients to do lots of coughing. That's why we have airway clearance and huffing prior to the cough. That's a little bit off on my soapbox, but it's also going to minimize the urinary incontinence if you're doing less coughing. I'm not saying don't cough. We need to cough. You need to get the junk out of your lungs, but at least make it a more effective, efficient cough. Maybe it's changing airway clearance. If when you're doing the vest, you can't control your cough and it's making you cough a lot, maybe you need to do something different, something like autogenic drainage that's gonna have a lot less coughing involved. So it may mean modifying your routine to help to improve on other things. And there's also referral to a specialist, whether it's a urogynecologist or a physical therapist who specializes in pelvic floor disorders. And usually what that involves is an internal exam, just like when you go to the gynecologist, but not for pediatrics. For pediatrics, they do not do internal exams. Everything is external palpation and treatment. So that's a whole lot of stuff that PTs can do. But there's still stuff that's going to get in the way. For those of you who were here last night for Dr. Reichert's talk, you heard about all the barriers and medication adherence. And it's not just adherence to medications, but it's adherence to these other things that we're asking our patients to do as well. So another part of my assessment is finding out why people aren't doing what they're doing. You know, why aren't you exercising? Is it because they just don't want to? Do they not have enough time? Are they too tired? Are they scared? Like I mentioned earlier, do they just not know what to do? They're afraid to exercise because they may overdo it, or they may waste their time because they're not doing enough. Are there financial barriers? You know, they really want to join a gym, but they just don't have the funds to do that, or they'd love to take dance classes or gymnastics. I also want to find out, how important is this to you? Yeah, you pee your pants when you cough, you're not getting better with the things I'm telling you to do, you should really go see a specialist. One patient, this was a long time ago, and I still remember it to this day, and it has changed the way that I talk with my other patients, and I don't push them to do things once I find out the importance, the barriers, the motivation. But she said to me, Karen, I just don't care. I'll put a pad on, I'll pee my pants, I don't care. And she had so many other things in her life that were more important. Her lung function was declining. She had been diagnosed with CF-related diabetes. She was busy with her kids, and incontinence was low on the list. So before I'm giving someone an exercise program, whether that's aerobic exercise or postural exercises or incontinence, I want to find out how important it is to them. How motivated are they to do it? Right? If you're not motivated, you just may not be ready. So really assessing readiness. Giving people choices. You know, what's going to fit into your life? How can we make this happen? For kids especially. Not saying you have to run on the treadmill for 60 minutes every single day. Who wants to do that? I think that's boring, right? But giving them choices of what to do. Our pediatric team has a behavioral psychologist, and I heavily rely on them for helping to break down some of these barriers and figure out what's going to happen. I've learned so much how to talk to not only my patients, but also my own children. Rewards are not just for kids. This woman here in the picture, and I don't know what it is with cats and CF, right? Is there something more to it? Like, do you know of many other patients? Because what this woman told me, During the clinic visit, we were talking about exercise, and she rolls her eyes and she looks over to her husband and says, he nags me all the time to get up and move, but you know what? I'm not gonna do it. I said, why not? What's getting in the way? She said, I'm happy sitting on my couch with my cats. I don't wanna leave my cats. And I was like, okay. I'm not a cat person. I don't get it. Like the cats will be fine. They're fairly independent animals, right? But I didn't say that. I just nodded my head. And she said, Karen, don't laugh at me, please. But have you ever seen those strollers that you can put your animals in? And I nod my head. And I'm sitting there with my laptop on my lap, and I'm typing as if I'm documenting what we're doing. But really, I'm Googling cat stroller. And I flip it around, and I show her, and she's like, oh my gosh. She's like, maybe I'm gonna have to save up some money. She didn't have much financially, but she's like, I'm gonna save up money, I'm gonna get that. And her husband nodded, and it was great. And then I said, okay, you get the cat stroller, are you really gonna get out and do it? And she said, maybe not. I said, okay, what's gonna work for you? What's gonna motivate you? Maybe you should get some kind of reward for doing this. And I look at her husband, I'm like, what can she get, for getting out and exercising? And she says, he can do the dishes. I said, all right. And she said, if I get out and walk 3 times a week, he does the dishes once a week. And I was like, whoa, that's not fair. If I'm doing something 3 times, you should have to do something 3 times. But she actually enjoys doing the dishes. I don't know. So it worked for them. And she sent me this picture 2 days later. She said, I told my sister about it, and she ordered it on Amazon and had it shipped to me. Karen, this is me at the top of my hill in my neighborhood. And she got out and she did it. So again, it's breaking down the barriers. The other thing that I see with a lot of parents is oh, rewards. I just can't buy more video games or spend money on stuff. I can't keep spending money on rewards. It doesn't have to be money. I can't tell you how many times I ask a kid, all right, you do this. You're gonna do your airway clearance twice a day for 7 days a week. What's the reward gonna be? One-on-one time with mom. Dad plays video games with me. We go out, play basketball, whatever. And they crave that one-on-one time. So it doesn't have to be monetary if you're looking at a reward system. All right. Moving on, back to those special considerations for exercise and CF. Osteopenia, osteoporosis, we need to build the bone bank. We need to think about it from a young age and do exercises that have high impact, that are strengthening the bones. If we have CF-related diabetes, there's additional blood glucose monitoring that should be done before, during, after exercise. Caloric intake, that better BMI with exercise that multiple studies have shown is only true if the caloric intake is there. So making sure you're working with your care team if you're starting an exercise program or changing an exercise program, and making sure you're getting the protein and the calcium and all that you need. I often will co-treat with our dietitian when people are changing things with their exercise. Avoiding breath holding, it's not good for a lot of reasons. Your muscles need the oxygen. It can also cause fluctuations in blood pressure and heart rate. We may need longer rest periods. Even with mild to moderate disease, you may need more rest periods than your peers need. In severe disease, it may be less cardiovascular type stuff and more strength training. And MES is neuromuscular electrical stimulation. So putting electrodes on the muscles and helping to strengthen that way. And that's something that's been successful, with people who have severe disease, maybe in the ICU and can't do as much. Resistance training, back to that HIIT training. HIIT training is not just for CrossFitters, it's for people with CF too. And I love doing HIIT workouts with my patients because you go hard for 20 or 30 seconds and then you rest. And then you go another 20 or 30 seconds, then you rest, and it really allows to get a lot done. After lung transplant, there's side effect of medication, so your immunosuppressants, your steroids can weaken the muscles, so you need to make sure you do targeted strength training. Precautions to be aware of, we should always be keeping our oxygen above 90%, so supplemental oxygen may be necessary when you start exercising. Again, post-transplant, heart rates may not be getting up to the target heart rate zone, so using self-reported measures of exertion and shortness of breath. With low BMI, again, the co-treating with the dietitian is super important to make sure the calories are getting in. Pregnancy, if it's a planned pregnancy, you really want to maximize not just BMI and lung function, but also fitness prior to pregnancy, because pregnancy really takes a toll on the body, and it's going to be that much more important to have that good pelvic floor muscle function as well. During a CF exacerbation, heart rates are going to be up higher because your body's working to breathe harder, fight off infection, so you may not do as much intensity. It may be a lower intensity than what you're used to. PICCs, ports, and tubes. Contact sports aren't going to be good if you have those things. With a PICC, doing any excessive upper arm movement or vigorous motions with the arm aren't necessarily recommended. Activities to avoid where you're going to have big changes in pressure, like scuba diving or like mountain climbing at very high altitude. So those aren't always the best for people who have CF. Hemoptysis and pneumothorax. If you have significant bleeding when you cough, you should probably put your exercise program on hold until you don't have bleeding for 24 to 48 hours, and then gradual resume. Same thing with pneumothorax, and that's where the breath holding is going to be super important that you avoid it, because that can actually expand the size of the hole. So you really want to make sure that you're healing before you resume exercise after pneumothorax. And guess what the side effect is to multiple physical therapy treatments? Airway clearance. Studies have shown that aerobic exercise does a lot to clear the mucus. However, it doesn't get down into those small airways. You still need to huff and cough if you're using exercise as a means for airway clearance. It should not replace your airway clearance, but it can definitely be an adjunct. And even if you're not looking at exercise as a way to clear your airways, it's going to happen probably, so you probably should be huffing and coughing even if you don't feel stuff right there to come up. Putting the body in different positions changes the way your lungs are ventilated. So if you're lying on your right side, the gas exchange, the ventilation to that right lung is going to be different, and that can move mucus. You also have the effects of gravity. So being in side lying is going to move the air through your lungs differently than lying on your back, different than sitting up and standing. So just getting in different positions is going to affect the airflow and airway clearance. Manual therapy techniques that a lot of physical therapists use, so whether it's rib mobilization, spine mobilization, soft tissue manipulation, all of those things are going to help the chest to open up bigger. And the way I explain it to my patients, you have CF working against your lungs. You don't want your outer shell working against your lungs also. We need to really maximize on how much expansion you get in your chest so you can get as much air in as possible. So if you're going to a physical therapist or a personal trainer who is not a CF specialist, it's important that they're in contact with your CF team, because there are these side effects of interventions that physical therapists do, or a personal trainer gets you exercising. I had a patient come back to me once and she's like, yeah, I'm working with a personal trainer, it's going great. We're not doing any cardio though, so don't worry. And I was like, why aren't you doing cardio? He doesn't want me to lose weight. So I was like, all right, you need to get me his number, and he's going to get a phone call from me, because I want to educate them that it's okay to do cardio if you have CF. It's actually strongly encouraged. So making sure if you don't have a PT right on your team, that your team is in communication with whoever it is that you're working with. Technology may come into play to get people moving more, whether it be phone apps or activity monitors. We recently wrapped up a study with our pediatric group at Hopkins, and we were giving them Fitbits and having them join a group to see if that would help motivate them. And we actually had a lot of fun with it. I'm still Fitbit friends with a number of the patients, and it annoys me when they beat me. And like the weekly step counter, the challenges that we do. We gave them food names to keep them to HIPAA. That's what I'm looking for, to follow HIPAA rules. So it was a lot of fun, and it continues to be fun to work with them that way. Ultimately, some motivation is required, right? There's a lot of stuff that we are asking our patients with CF to do, and exercise hopefully isn't another chore. Hopefully it's a way of life. It should be fun. It can be family time. And this is the guy, this picture is probably 6 or 7 years old. He's in high school now, and he beats me all the time on Fitbit. Anyway, it can be done during airway clearance. After every 15 breaths into your acapella, stand up and do 10 squats. Do some lunges, do some push-ups, march in place. Only allow yourself to check emails or social media while you're on the treadmill or a stationary bike. Earn your screen time. Tell your kid, if you go outside and run around and play for 30 minutes, you can have 30 minutes of video games. And you can do that for yourself too. It works well, if you're self-disciplined as an adult. Work and homework breaks. If you're someone who tends to get lost in your work and just sit at your desk all day long, maybe you need to set a timer as a reminder to get up and move. So in summary, what does physical therapy do for people with CF? We assess posture, range of motion, strength, a whole bunch of things. We stretch and we realign. We retrain the brain, retrain the muscles using cueing, whether it be hands-on cueing. We use pictures, we strengthen, and again, in a functional way, not just like standing still, doing exercises, but making sure that they can function with what we're doing. And airway clearance also, looking at posture, even if as a PT you're not the primary provider of airway clearance, we need to be concerned about what their posture's like, and are there different breathing exercises that can be done. Huffing before you cough, again, can't stress it enough. So why PT? Because of this. This guy on the left is November of 2015, on the right is September of 2016. And other than a haircut, some glasses, and a tan, can you see any other changes? Take a look at his chest and ribs. He had that kind of flared rib cage, this excessive sway here. Just everything was lifted up. You can't see it because his arm is blocking, but that sway is there in his back. And then almost 9.5 months later it was, after he had been exercising, he has some muscle definition. Those ribs are now pulled down, setting the rib cage on top of the pelvis. And again, I'm so glad I took that picture in 2015. He knew he had changed, but when I sent him the pictures side by side, him and mom were blown away, as was I. I had this slide up earlier, why PT? Because of all these things. This girl couldn't get through her workday, okay? She had pain, she had shortness of breath. She recognized that her breathing pattern was changing as she went on in her day. She couldn't even think about exercising. That big change there. And you don't know her like I know her, but the picture on the left, if you look at her smile, that's like, okay, Karen, you're taking my picture, I'll smile for you. The one on the right, her eyes are closed, she's more relaxed, she's smiling. Look at the shoulder, the arm, how much closer it is to her head. When I do this side bending measure with patients, I'm not just doing the measurement, but also looking at the quality. And you can see that one on the left, I could put a 2x4 along her rib cage. And there's not much opening through her waist area either. On the right, the after picture, she has definitely more curve through her spine, more opening through her waist. And it's just amazing. She was the one that was on the wedge. Also, we worked on breathing mechanics. In just a few sessions, her pain was gone. Her stress incontinence was better. By like the 4th or 5th visit, she's like, okay, I'm ready to exercise, let's do this. And just overall improved. When she came to PT April of 2016, I don't remember the exact numbers, but I want to say her lung function was in the low 30s. And you may have heard the statistic that people with CF normally lose about 1% to 2% of their lung function over the course of the year. A year later, she was up at 40%. It's not just because of PT. There are other medications and things like that, but we know PT helped, and getting her exercising really helped. So If you don't have a PT on your team, there's the American Physical Therapy Association website where you can find a PT. But what I would recommend before that is talking with your CF team. They may have a physical therapist not physically in the clinic, but someone connected, in the hospital. If they don't, it's not a hard and fast recommendation or requirement. But typically hospital-based clinics, hospital-based PT clinics are going to have more experience working with more medical conditions and not just back pain or knee pain or shoulder pain, where you might get PTs who just know a little bit more about the medical side of things. But always, always, always talk with your team. That's my adult team, most of them anyway, on a team building day before heading out to see the Orioles. Other resources for you, you may know about a lot of these. I know some of these foundations are right outside the door. Or in the veranda room. I saw some tables also. Resources to get you moving more. The Yoga for CF DVD is a free yoga DVD available from the foundation at that email. Check your local parks, rec centers, pools. One family came to me and said, all I did was ask, my local pool. I told them my kid had a medical condition. I explained CF and how important exercise was, and they gave us a free family membership. So it can't hurt to ask. Also, the National Park Services, I know a couple years ago they had every fourth grader in a park, so there may be things available out there in your community. The CF Foundation also, as of last fall, awarded 31 centers a grant to partially fund a PT position in their centers. So this year there are 31 new centers that now have PT. That's it. Thanks. That's the bigger Hopkins team, including alumni, and then my team, my personal team on the right there. And I thank them all for giving me support and allowing me to do what I do.